Raoul Mon from Felix Houphouët-Boigny University in Abidjan. 48 weeks efficacy of a third-line-based darunavir plus raltegravir regimen in HIV-infected adults who failed second-line protease inhibitor-based regimen in sub-Saharan Africa. Theliao study.
Thank you, Mr. Chairman. And thanks to the IAS organizers for giving us the opportunity to present the final results of the Theliao study, reinforcement of adherence and switch to third line in HIV-infected adults who failed second-line ART in West Africa. In sub-Saharan Africa, ART regimen sequencing is based on WHO guidelines that recommend to start with an NNRTI-based regimen and then switch to a PI-based regimen in case of virological failure. In the recent years, there has been an increase in the access to viral load monitoring and to second-line drugs. Because of this, there has also been an increase in the number of patients on second-line ART diagnosed with virological failure. Meanwhile, access to resistance tests and to third-line drugs remain low. In this context, there is a need for strategies that help physicians to decide when to switch to third-line ART. Not too early, in other words, switch to third-line when you have virological failure but still a high genotypic sensitivity score. And not too late, in other words, delay the decision of switch that leads to the risk of accumulating resistance. We did a pilot study named Theliao to assess one of the strategies in 4 West Africa countries, Burkina Faso, Côte d'Ivoire, Mali, and Senegal. We included in this study adults who were on a PI-based second-line ART and had confirmed virological failure, defined as 2 viral loads above 1,000 copies within the past month. The Theliao study had 2 phases. During the first month, participants had an intensive adherence reinforcement program that I will detail in the next slides. During this phase, they continued the previous treatment. At month 4, a decision was taken based on the effect of adherence reinforcement on the evolution of viral load. If viral load fell below 400 copies or decreased more than 2 logs compared to baseline value, patients continued the second-line treatment. Otherwise, they switched to third line. The study primary outcome was virological success at month 16, defined as viral load below 50 copies. The secondary outcomes were death, resistance, and tolerance. All participants had therapeutic education and then chose as many adherence reinforcement measures as they wished among the following: involvement of a relative, pill organizer, weekly phone calls, alarm reminders, SMS, home visits, extra visit to the study center, support group, adjustment of ART drug doses, adjustment of non-ART drugs. Viral load was measured every 3 months, with results provided in real time to clinicians. The month 3 results was used to inform the month 4 decision. If the decision was to continue second line at month 4, a switch to third line was further proposed whenever the patient had 2 consecutive viral loads above 1,000 copies at any time during follow-up. Resistance tests were performed at baseline and at month 16 for all samples with a viral load about 400 copies. The results of this test were only available at the end of the study. They were used retrospectively to interpret the decisions taken at month 4, which could only be based on the effect of adherence reinforcement on the evolution of viral load. The decision taken at month 4 was retrospectively deemed inappropriate if the decision was to switch, but the resistance test retrospectively showed that there was no resistance to the ongoing PI, and the genotypic sensitivity score, was 3 or above. Or if the decision was to continue second line, but the resistance test retrospectively showed that there was a resistance to the PI, or the genotypic sensitivity score was below 2. In all other cases, the decision was deemed appropriate. Finally, resistance accumulation was defined as new resistance mutations occurring between day 0 and month 16 in patients with a viral load above 400 copies at day 0 and month 16. 198 patients were included in the study. The median age was 41 years. The median baseline CD4 count was 238. The most frequent ART regimen was TTF-XTC plus lopinavir ritonavir. The median time spent on ART was 8 years overall, 3 years on first line and 3 years on second line. The median viral load was 4.5 log. After the phase of adherence reinforcement, during which 2.5% of patients died, the decision at month 4 was to continue second line in 66% of patients and to switch to third line in 32%. Overall, at the end of the study, 8% of patients had died, 2% were lost to follow-up, 51% were alive and in active follow-up with a viral load below 50 copies, 23% at between 50 and 400 copies, and 17% at more than 400 copies.
Better.
Patients who continued second line or switched to third line at month 4 at similar percentages of virological efficacy at month 16. Between 70 and 80% of patients had less than 400 copies, including between 50 and 60% with less than 50 copies. When considering the probability of having at least one viral load below 50 copies during follow-up, patients who continued second line or switched to third line at month 4 also had similar probabilities of reaching less than 50 copies at least once. These probabilities are higher than the percentage of patients with less than 50 copies at month 16 that we saw in the previous slide, because some patients who reached less than 50 copies at least once at more than 50 copies at month 16. And finally, here is the detail of the other outcomes. According to month 4 decision, as you can see, third-line drugs were very well tolerated. Among patients with more than 400 copies at month 16, 82% and 71% had one resistance mutation to at least one ART, respectively. Resistance mutation accumulation was found in 5% and 3% of patients, respectively. And when the result of the resistance tests were available, month 4 decision was deemed appropriate in 81% and 73% of patients, respectively. In conclusion, in settings where viral load tests are routinely available, but not genotypic testing, an intense adherence reinforcement phase used as a tool to distinguish between patients who can still benefit the current regimen and those who truly need a potent third-line ART allowed us to take appropriate decision of switching or not switching in most patients. Resistance accumulation was rare, and third-line drugs were well tolerated. Accessibility to viral load monitoring, to third-line drugs, and to adherence reinforcement measures should be reinforced. Our thanks and gratitude go first to the participants in the study, and then to all those persons and institutions who took part in the realization of this study. I thank you for your attention.